This is illustrated in this slide a little bit better. Again, the incidence of ALL being highest in the 0 to 4-year-old age range and then going down. And in the adult patient population, ALL is only about 20% of leukemias compared to 80% of non-lymphoblastic leukemias. It's exactly the reverse in childhood, but it's a spectrum because ALL goes down and non-lymphoblastic leukemias increase. Again, here's your Hodgkin's disease and bone tumors, which tend to be cancers of later in the childhood age range. Neuroblastoma, again, rarely seen beyond the early age range, and Wilms tumor fairly similarly, although there are occasional adult cases of these cancers. Now, there's been a lot of attention given nationally to the idea of what's the paradigm for proper treatment of children with cancer. And the American Academy of Pediatrics has published several serial guidelines for what makes up an appropriate pediatric cancer treatment program. And this slide illustrates that. And I want to bring this up because it puts into context what we're trying to do here in Ventura and trying to bring together the programs and the resources we have at our institution with the resources we're building here to really together make the kind of program that you need in order to properly take care of a child with cancer. And I think the key is multidisciplinary approach to both diagnosis and treatment. And the diagnostic side has really become obvious in the past few years as we get into the molecular medicine field and we start seeing that the diagnosis of many of these cancers really may depend on molecular assessment. Some pathologists think that other than looking at a slide on the microscope and saying that's the cancer, that the rest of the diagnosis of the kind of cancer you're dealing with is going to be done at the molecular level in the future, because it not only is more accurate in many kinds of cancers in telling you that this is a particular malignancy, but it also gives you both prognostic information based on the genetic pathways and genetic fingerprint you get, and also gives you ideas about therapy. It'll lead us to targeted therapy. It already is leading us to targeted therapy for these patients. So molecular diagnosis becomes extremely important, as do all the other elements of diagnosis. Tumor imaging is getting even more sophisticated now with CT PETs and specifically labeled radiovisible compounds that are now being used for specific cancers. We have complex immunophenotyping that is done that is important, particularly in the hemopoietic malignancies. As I said, cytogenetics has been important, but I think that's going to be replaced ultimately by the molecular analysis, which is much more detailed and gives you more information. On the therapy side, I think you're probably all familiar with the various elements that you need to have available in order to appropriately take care of a child with cancer. And I want to stress they're not only the medical specialties you see up here. Nursing is critical. You must have nurses who have experience and are trained in oncology care, and they probably, in my mind, are the most critical element of the treatment team, frankly. You need to have pharmacies and pharmacologists who are aware of some of the drugs we use and the unique aspects of delivering them to various age children. You need all of these supportive care areas, including psychosocial support, rehabilitation, and finally, and you'll hear some from Dr. Fryer, I think, the importance of having a long-term follow-up and surveillance program for late effects and the ultimate results of the care. And I'm going to show you a great example. I'm going to steal a little bit of his thunder a little later, but show you a great example of why that's important. Now, you know, despite all the negative things you still hear from lay people primarily about chemotherapy, I did a talk show on NPR about a week and a half ago about this child with Hodgkin's disease who had refused to get therapy. And I was interviewed along with a very well-known medical ethicist from Philadelphia, University of Pennsylvania, and they allowed calls. It only took one call, and it was a guy who called up and said, you know, chemotherapy is terrible, they're poisoning everybody, you're just doing that to make money, and, you know, this is horrible stuff. So that still is, there's still some of that out there among some of the lay public. But the reality is that what has made the huge difference in approaching childhood cancer over the past half century has been the realization that childhood cancer is really almost always a systemic disease. And in fact, adult cancers to a large extent are, but haven't been appreciated. And when it was understood that that was the case, that even though you couldn't see disease in many patients except for, let's say, a primary site, that in fact there was widespread disease present at a microscopic level, that really led to the breakthroughs in the past century. And it's illustrated, I always like to show this slide because it's illustrated very well here. Here you have a half-centimeter mass is probably, arguably, just at the edge of being detectable by even some of the most sophisticated techniques we have now. And you're already looking at 10 to the 8th cells, and cancer cells in a half-centimeter mass. So anybody thinking that negative scans mean there's nothing there, I mean, it obviously is not true, and this was an important realization. Most patients, by the way, who present with cancer, whether it be leukemia or solid tumors, present with about 10 to the 12th cell burden, cancer cell burden in their body at diagnosis, or around the equivalent of about 1 kilogram of tumor in their body. That's pretty much the average. So, but as you can see, there's a huge area here below the visible, and certainly 1 centimeter is probably visible by. There's a huge area below here of cell numbers that could be present that we don't see. And realizing that that patients needed to be treated as systemic disease made a huge difference. So here's what's happened. This is the latest SEER data. SEER data, by the way, is the nationally collected data collecting all cancer survival data in some very specific states that participate in the SEER program, California being one of them. It's not every state in the country, but quite a number of registries who have complete data on all the patients with cancer in the area participate in this registry. And this is the latest data. It's always a number of years behind in collecting. So this is the latest data. And you can see that over the past really 25 to 30 years, we have seen about a 20% improvement in the overall survival from childhood cancer, from 60% to now running around 80%. And that is the figure we're at about now. But 80% survival. The curve generally plateaus or starts to plateau pretty well after this point. If we were to draw a curve for 1950, I was a little bit, I was a young child at that time. The curve would have gone like that, and just about everybody was dead within a year, and the curve dropped precipitously. If one were to draw a curve in the late 1960s, when I started in my medical field, it would have been something like this. It would have gone down to about 40%. If you go in the early 60s, it would have been around 20%. That's when we first had some chemotherapy available. And then, as I said, in the 50s, it went straight down to the bottom. Cancer truly was a fatal disease. So we've continued to make progress during this past 25 or 30 years, although had made tremendous progress before that. I don't know, I may need the lights down a little bit. Can you see that slide okay? I can't, from here it's a little bit, maybe you can see it better than I can see it. So I tried, I couldn't find a slide updating the survival data of various cancers to the mid-2000s, but I did find the raw data and was able to update a slide that I had that went through the late 1990s with this data. And this is, again, here's the overall survival, which is this green line here, and you can see this green line here, and you can see it's around close to 80% or right at 80%, which is equivalent to the SEER data you just saw. But you notice that there's quite a distribution of the kinds of cancers and how they do. For instance, patients with Hodgkin's lymphoma in the pediatric age, whoops, what happened to that?
Sorry, they can't see it with the video.
Huh? Oh, they can't see it, okay. Sorry about that. Okay, so Hodgkin's lymphoma, you can see they were up above 90%. I think the current figures for Hodgkin's disease in the pediatric age range is 96% survival.